Just before we talk about the coming Edo State election, the big one, let's talk about your health. It's absolutely important to pay attention to our health because, who knows, something might happen. And this morning, we're touching on that important subject of patient safety. The world came together to talk about it, and we want to ensure that we're not left behind here in Nigeria. At one point or the other, you will have been a patient. Maybe when you were born, you were some sort of patient, or from time to time when you seek medical attention. So this is a conversation that covers everybody. And this morning we're joined by three individuals who will help us get a sense to where Nigerians are, the challenges we're facing, and how to ensure that next time you go to the hospital, you get the very best attention from all of the health workers. Mr. Pascal Achunine, the very first guest who joins us right here in our Lagos studio, is Executive Director, Health Emergency International, and a social entrepreneur. And joining us virtually is Professor Sonny Semede, who's lead consultant to the Federal Ministry of Health and Patient Safety Policy Development, a visiting professor of Patient Safety and Care Quality Leadership, Federal University of Health Sciences, Otokpo, Nigeria, and specialist advisor, Care Quality Commission, England. Also joining us virtually is Professor Aminu Mohammed, who's the President, Medical and Dental Council Association of Nigeria, and Professor of Surgery, Bayero University, Kano. Gentlemen, good morning and welcome to the Morning Brief.
Good morning.
Thank you very much.
Thank you.
Well, this is a very important conversation, but conversations like this happen in a context. There's a global context, and that's why the world came together through the World Health Organization to talk about this. But there's the Nigerian context as well. So I want us to begin from that. Now, the shadow over everything in Nigeria today is the economic situation, the cost of doing business, the cost of living, which now goes to the cost of healthcare. So I'd like to begin with you, Mr. Achunine, because there's a tendency to speak about these things in isolation, when in fact, they happen in the context. So speak to us, because we've heard hospitals, care providers speak about how the economic situation is impacting health delivery, from the power situation, the cost of procuring medications, equipment, and the rest. So how is this impacting generally on healthcare delivery, and then specifically on patient safety? Is this harming it, and to what extent? Let's start from there.
Thank you. First, my heart goes out to residents and people in Borno and Kwara and other places affected by the flooding. Obviously, it has health implications, it has safety implications. As at 2022, when the National Bureau of Statistics published that 133 million Nigerians live in multidimensional poverty, one of the key indices affected was health. And as a country, from the national government to the subnational governments, in terms of attention required, we are already lagging behind budgetary allocation, infrastructural deployment, and even the manpower plus technology that you see in even smaller countries across the world. So the economic situation is impacting negatively, starting from the drivers of it, the health professionals, and that is reflected in the number of people who have left the country, the Jacqua syndrome. And it means that the few who are left behind or left here, most of them are overstretched. Go to any public health facility, you see a crowd, you may think that there is a football match or a party program going on, because some people get there at 4, 5 a.m. to enable them access care. And we have few personnel that are now attending to this. And you must also put this side by side with the grassroots public facility, which is the primary health care centers, where medical conditions that are non-chronic, ordinary, should be attended to. Most of them are less than 20% of them are functional. And then related to it is the cost of transportation. So let's look at another important indicator that is going to impact on safety. The cost of transporting from where you live to the nearest public facility. People that could afford it 2-3 years ago cannot do that now. So many people stay at home, watch their health degenerate. And the tragedy is that the cases that typically could be treated end to end in 3-5 days, they get out of hand. When they are now rushed to the facility, they are in a very messy state. So that is one key area. And then, of course, you know about this power. In the last 8 to 9 months, one of the facilities I visited while in the East in the last week, they were given a bill of about 5 million. They negotiated to 1.5. And the agencies, the authority, the power holding, the energy supplier, let me put it, they could no longer, at a point, they cut them off. And so, as much as that facility is concerned, they will not operate at up to 20% capacity.
So clearly, this is impacting adversely on patient safety.
Sadly, that's the reality.
Because, and I'll take this to Professor Semede, if you look at what the goal for this year is, they essentially say, get it right, make it safe, improving diagnosis for patient safety. So the slogan is, get it right, make it safe. But in the context that Mr. Chunine just painted, and which we all know about, what a lot of people are used to is, a lot of times they go to the hospitals and what they find is cranky healthcare workers. The nurses seem not to be happy. Now we have great nurses, I must say that. But a lot of people go to maybe public healthcare service providers and even private, and it looks like they don't want you to be there. They're cranky with you. You ask for something, you don't get the help you need. There's a JAPA challenge as well. So in that same context, Nigeria is or has developed our policy on patient safety. So how do these things match really? You have a bird's eye view of the situation. So how challenged is patient safety really in the context of all of this from where you sit and that policy which we have developed?
Thank you very much, Kayode, and thank you to Bukola. And good morning, our viewers. I am Sonny Semede. I am joining you incidentally from Benin City, Edo State, and I bring a message of unity. A unity between all the politicians. One thing they agree on today, even though we have a massively divided electorate, I can tell you that Oludi Akpakomiza and Aswe Floret, we all agree on one thing. There's a need to come in and work as a team. Kayode, you did talk about the theme of this year's World Patient Safety Day, which is improving diagnosis for patient safety, get it right, make it safe. But what you did not add was it's a team effort. A team effort that is clinicians need to work with their peers, work with pharmacists, work with those in the labs, work with the patient, their families, the community, work with policymakers and everyone. So the solution is teamwork. And people will say, what has the family got to do with making the right diagnosis of appendicitis or cause of fever? People self-medicate. Not all fevers are typhoid or malaria. When you have a member of your family who is complaining of fever, advise them to have a checkup. And when they go for their checkup, if the doctor is not sure, the doctor needs to send them for a test after doing the physical examination and make sure they get it right. In order to get it right, the lab needs to be well equipped. And this is why we need the policymakers, we need the politicians. And this is why the World Patient Safety Day was endorsed by the 72nd World Health Assembly to bring patient safety issues to the fore and make sure that everyone is engaged with this. We need the politicians, policymakers, we need the traditional leaders all coming in to show solidarity. And I'm pleased that it is gradually beginning to happen. The first time we had a go at this was as far back as 2002. That was the 18th resolution at the 55th World Health Assembly, which asked countries to consider the issue of patient safety. So it was just, think about it. And 17 years later, it was found that virtually nothing has been done in several countries. So a plan was put in place. And I'm pleased to say that the federal government of Nigeria, through the Federal Ministry of Health, has engaged with this global initiative, engaged since 2019 when the theme was Speak Up for Patient Safety. Okay, bringing patients from the margins of care right to the center and the heart of care. And during the COVID, you can remember our theme was health worker safety, a priority for patient safety. And then we advocated for PPEs, for sanitizers, for water in the hospitals. We advocated for ventilators. And most importantly, we asked for attention to be paid to the well-being, mental health and well-being of our healthcare workers. And so a lot of progress was made there, and what we're calling for this time is that the progress that has been made should not be temporary issue. They should continue because the problems have not gone away. In 2021, we focused on maternal mortality, where we in Patient Safety Africa have developed a little tool with which you can fast track a patient from the rural area to the referral center where there's ICU for actively deteriorating severe cases like preeclampsia, eclampsia. And in 2022, it was talking about look-alike, sound-alike medications, how to reduce the incidence of medication errors. And last year, again, we talked about raising the voices of patients for patient safety, developing a patient safety charter, which we did at the World Health Organization level. Again, I'm pleased to say that the Patient Bill of Rights in Nigeria 2018 contributed to that global initiative. And right here, right now, this year, it is diagnostic safety. It's a teamwork.
Right.
We need all persons to be a part of it, to take care of our patients. The healthcare workers need to be helped to take care of their patients. And that's why the issues in Kaduna right now is a very serious issue. There's no place for banditry in our hospitals. We demand that they be freed. Our hearts are with our colleagues in Borno State as well as they battle with the issue of floods.
All right, Professor Semede, thank you for that all-encompassing commentary on the progress made with international engagement on patient safety, home and abroad. I'm going to come to you on the Bill of Rights for Patients later on, but let me go to Professor Aminu now, who is from the Medical and Dental Council Association of Nigeria. I'd like you to speak to punishment for erring medical staff. And, there are quite a number of stories out there of wrong diagnoses, patients who talk about, operating equipment left in their wombs, left in their bodies, and as a result, they've begun to experience paralysis, or they're unable to use their limbs correctly anymore. And reports out there to the effect that punishment for erring medical staff are few and far between, that they get away with a lot of it. What perhaps is in the patient safety law in Nigeria that patients who have similar complaints can invoke such that they can get justice and not be have to live with being permanently maimed for life?
Thank you very much, Bukola. I want to make a slight correction on the organization I represent. I'm the president of Medical and Dental Consultants Association of Nigeria. This is the association of all specialist doctors in the country. On your question, diagnosis is a process. And just like the way Professor Soni mentioned, is that it is a teamwork and it is a process. It is a process that involves a detailed history taking, thorough physical examinations, and relevant investigations. And all this have a lot to do with the adequacy of the number of staff and also the teamwork as mentioned. Sometimes you find out that health workers do not work in isolation. That is why we always advocate for teamwork. As regards to medical negligence, you find out that the system sometimes creates that opportunity when there are inadequate numbers, and you find a lot of charlatans and quacks engaging into procedures and processes that are beyond their knowledge, that is beyond their qualifications, and beyond what even the law advice allowed them to do. you find out that in some situation, misdiagnosis or errors in treatment are to do with the system itself. Systemic failure sometimes is also the issue. When you are not properly equipped, when you are overworked, followed with a lot of burns out, instead of you, for example, if you take the ratio of doctors to patients in Nigeria, it's expected that as a standard, 1:600, but you'll find out that what we have now in Nigeria is 1:10,000. In a system where you need to allot about 20, 30 minutes to see a patient, in about, let's say, 5-hour walk, you are supposed to see at least maybe 10 to 15, but you are to see about 25, 30, and sometimes even 40 by one doctor. So you can see that the system is also an issue. We are making a lot of efforts in terms of the training of and equipping of our medical students to become proper doctors, and also the postgraduate medical training to ensure that we have adequate training and well equipped to take care of highly complex medical and surgical diagnosis and management. Right. So in this situation, you find out that our doctors, when they get to appropriate environment, they do much better because facilities and the enabling environment are there. Those that are within the country, we are making a lot of effort. Sometimes you make a diagnosis based on a lot of experiences because the diagnostic facilities are quite low in number, and also the affordability.
Professor Aminu,
you can recommend. Yes.
Pardon me. Are you saying that the shortfall and the fact that medical staff are being overwhelmed is an excuse for medical negligence? And to ask more specifically, how many erring medical officers have been served punitive action in the last 1 year?
In Nigeria, you find out that it is only the medical profession that are erring and publicly investigating, and in some situation convicting their own members. The council is making a lot of effort to sanitize that. But what people need to understand is that the council does not go looking for this medical negligence or misdiagnosis or issues to do with malpractice. The members of the public need to also report to the council. And once it is reported, you find out that there are thorough investigations, and these investigations are done in public. And you are aware that a lot of people have been deregistered, a lot of people have been suspended from practice, and a lot that doesn't have anything to answer have also been acquitted and discharged. So the Medical Council Disciplinary Committee, which is the arm responsible for this, are also doing a lot of this. And public can testify that it is the only profession that tries its own publicly, so that people will also judge by themselves.
All right. So I want us to bridge the gap. There's a tendency for us to speak from where we sit naturally, but also for the people who are watching who have real experiences when they go to the hospitals. Who, I mean, imagine a mother who was having a baby, for example, and during the birth experience, she was told to push, and this is a real example. Was told to push, keep pushing, by the doctor there, without knowing that the umbilical cord was tied around the baby's neck, and the woman kept pushing. So both the mother and the baby were exhausted. The child lost oxygen for some time, and you can imagine years after, the child, the parents, the family still living with that reality of what happened then. The child having developmental issues, and I think that's why Bukola was reiterating that point about what then happens next. And these are examples that are scattered across the board. So I want us to speak to how to fix that challenge, because there's the Nigerian context. So let me come back to Mr. Chinene, because you also work across across the different sectors,
yes.
the ecosystem of healthcare in Nigeria. So what have you found to be the major challenge? Because it's one thing to try to proffer solution, talk about patient safety, but we also need to know what the real problem is. So as much as we want to punish, we're also ensuring that we're giving them enough before the punishment comes. And say, well, to whom much is given, much is expected. So what have you found to be the key challenge of the healthcare sector in Nigeria that we keep seeing all these issues?
So I want to reiterate that most of the things around patient safety in the first place, some of them stipulated by other guests, I call it a journey. But there are gaps as you use. How do we bridge the gaps that connect with the now? Let me give you an example. One of the pediatric facilities, public facilities here, do not have 24-hour light. And their neonatal ward, where we have incubators with preterm baby, children born preterm, they introduce what is called kangaroo mother care. So at a point in the night, 8 p.m. or so, the light goes off. They bring a relative of the baby to come and nurse till the next morning, and a lot of them lost our lives. A lot of lives are lost in the process. Our organization, Health Emergency Initiative, will be working with this facility, and typically we pay hospital bills of indigent patients and accident victims the first 24 hours. So we saw that this was leading to avoidable deaths. We reached out to one of our partners that is into solar energy, and they installed 5 kVA solar in that facility. That guarantees that there will be 24-hour light in that critical unit of the facility. Imagine we had that the neonatal wards of various facilities having uninterrupted power. It means that when we talk about patient safety, including that baby that is born preterm, he could be a president, he could be a professor any day tomorrow, that baby has that safety through that process. And interestingly, the cost of deploying that, because you may not have for the entire facility, but the critical unit was not huge. So that can be that playbook. Then let's go to the road traffic accident victims. I'm sure you are aware that the publication, it was even relayed by your station in 2018, December 13, that road traffic accident is the biggest killer of young people in Nigeria, people between 10 and 35 years. Right? Most of our organization had to sign an MOU with the likes of FRSC, National Orthopedic Ibobi, FMC Butemeta, and other entities that are involved in emergency response. The reason was the first 24 hours, over 50% of crash victims die. But there's this culture, I'm sure we know about, no deposit, no treatment, or no bed space. Why are they doing that? Because there is no one that provides initial deposit for them to access care. We have over 72% survival rate in the cases that these facilities brought into our ecosystem, because there is an organization that is standing as next of kin at that moment to pay. So when we talk about, I've had instances where a road safety personnel went to several facilities, and you're talking about patient care now, patient safety, and they said no bed space, even for an agency like the Federal Road Safety.
So at the heart of it basically is funding. We need to start thinking of...
and it's attitudinal, and then when there's need for collaboration. So government cannot fix this alone. Private sector, like the case at that pediatric facility, was a PPP. Social sector, as we represent, a private sector entity, and then they got...
Let me pause you for a moment, Mr. Chin. Pardon me, we're due for a break, a very important break. But when we return, we're going to talk about how to now be more creative and deliberate, such that the policy we have, all those documents we have, are brought to fruition because all the other parts are put in place. We'll still have the pros joining us virtually, but we'll be back in a moment to speak about all this important conversation, plus the Edo election. It's crunch time for the people of Edo State. So stay with us right here. The Morning Brief will be back.
Welcome back. And just before break, we're having an all-important conversation on patient safety and the concerns, the factors that work against that subject matter in our healthcare systems. We also have three gentlemen who have joined us for this conversation. Thank you so much, sir, for holding on. Mr. Chudume, we also have Professor Isedeme and Professor Aminu, who join us via Zoom. We're going to conclude your thoughts on the challenges within the system before I quickly take you to Ms. Professor Isedeme.
So when Prof was speaking about punishment or what the council does when there are incidences, so there's insufficient disclosure. The public perception is that there is no consequence management. If a private facility, a public facility, an incident was reported, and it was in the public domain, even if it is in private, just an anonymous communication that came to you, you must demonstrate transparency that this case, you went to the root cause of it, these were the reasons responsible for this. This person had been, after investigation, is considered innocent, acquitted. This person was guilty and has been sanctioned. It builds public confidence in reporting or escalating cases in the future. And we don't need to go over the same error. It happened in X hospital, it happens again here. But when there is, as a council, as in a body, you take those measures, people will confidence in what you do and what you represent will be higher. And I also want to underscore the fact that the media, I'm glad you brought this to the folk. Many people do not know about how the National Health Act of 2014 protects patients' safety. There must be greater level of advocacy for people to know that this, you can go to a doctor and what drug is he giving you? Let me give you a typical example. Most Nigerians think that when you go to a doctor and he prescribes so medication, you should go ahead with it.
And that's where I'm headed with Professor Isedeme, actually. There's a national policy document on patient safety that has been developed. Professor Isedeme, I'd like you to educate Nigerians on what's contained in that document, specifically about, the patient bill of rights. When you go to the hospitals, many times when diagnoses have been done, the medical practitioners do not quite communicate with the patient, not even with the patient's caregiver, who happens to be a family member, and the patients are left in the dark. So what questions should the patients be asking in that regard? And apart from that, when damage has been done in the first place, patients are not even educated on how to go about seeking redress. So what's contained in that document as well about how to seek redress when a treatment has gone south and patients have lost the use of a certain organ of their body?
Thank you very much, Bukola. And thanks, Pascal. Thank you, Professor Aminu, for your contributions here. May I just crave the indulgence of everyone here. These things seems to be, it's a major issue, and there are many people approaching this issue from several angles. And I have to say that majority of them are right. Whatever your experience, nobody should doubt it. But could you just give me some time to explain some very basic things so that we can have a better understanding of the issues of patient safety? Doctors, nurses, pharmacists, and clinicians go to work to try to do a good job. But despite their best effort, we have found out that about 134 million people globally get harmed in care. Up to 2.6 of them die. And we have found that nearly 80% of those cases are preventable. That's my starting point. How do we begin to prevent these things? What are the issues causing these problems? Rather than bouncing on the problems and trying to blame the doctors and the doctors blaming illiteracy. So let me give you a few things, which is the background from where we began to develop the policy. In a system, you see, as far back as 1993, there was a gentleman in Canada, it's called DuPont. He listed a few things he called the dirty dozens of human factors. He listed the reasons why accidents happen in transportation. This was not even in healthcare. And he listed the issues of distraction, he listed the issue of overload, overwork, fatigue, lack of resources, lack of communication, poor training, lack of awareness, poor teamwork. And believe me, these DuPont factors we call human factors, a dirty dozens of human factors, are still very evident. So a lot of the things people will say from different corners will actually be linked to these factors. The thing is, if you go back to this, how do we begin to deal with these dirty dozens of accidents, dirty dozens of human factors, which are the roots of accidents? Critically, there are issues, culture. You're talking about blame culture, and you're thinking that this might be a blame-free culture, that doctors are writing their homework and marking it. But we have moved away from that. There's a system, you blame everybody, they hide all the incidents, nobody's learning from them. Blame-free culture, there's no place for it, because when you have, malicious intent, when you have risky behavior, there has to be accountability. And that's why we've come to the point of just culture. In a just culture, there's transparency, there's honesty, there is openness, there's free communication. People are free to document what has happened. And, so there's incidents reporting so that learning, continuous quality improvement can occur. Even where this has been in place, right here in MDCN, in many countries, they have a professional duty of candor to be able to do this. Unfortunately, as Robert Francis in England showed in the Mid-Staffordshire case, the professional duty of candor is insufficient. We need a statutory duty of candor. That's one of the things Patient Safety Africa has been working on. And going back to your question, Bukola, Patient Bill of Rights number 12 says you have a right to complain, but it didn't say more about that. Not only do people have a right to complain, they have a right to have their complaint listened to and acted upon in a timely manner. And that's why we have a duty of candor and a duty of candor process. That's one of the things we have put in this, strategy document. Going back to this strategy, so we understand the issues in healthcare, the issues that lead to various incidents that are reported in the public. So rather than just talking about the incidents, we go to the root of it. What is patient safety after all? Patient safety is a framework of activities that creates behaviors, procedures, protocols, environments, technologies, cultures that consistently reduce incidents of harm. So it is these behaviors, the strategies, the procedures, the protocols that we have looked at. Where has it worked? Which countries has it worked in? How did it work? So we put all these things in this strategy document.
And I think the goal, pardon me, Prof, I think now to push it forward, we now need to break these things down into tangibles for all of the players, and talking about patients, families, and even the healthcare providers, so everybody knows what is demanded of them, at least according to this policy. So everybody is well equipped, and I think that's a lot of work that we have to now do, maybe collaborate and ensure that these things are broken down into digestible bits for people. So everybody is speaking from a place of knowledge, from a place of understanding. But I need to come to Professor Mohammed because of our time now on this. People have asked, yes, it's important to, take punitive actions, but it's also important to ensure that there's the enabling environment. And I know your association is always big on that. As you speak about ethics, you also look to the welfare and all of them. But people have also asked, how much of disclosure is made regarding these punitive measures taken? So everybody's on the same page. We know, okay, I can search a doctor's name, for example, and see the profile, or this person has had this case, has done this. A lot of people don't know about that, and they always wonder, how do you want us to trust the system if it is not transparent enough? So is that something being worked on? Can Nigerians easily access the profile of a doctor as you can do in other parts of the world? Just see the profile, see where this person has worked, were there any complaints, what was done, and then it's easy to carry on from there. Prof.
Thank you very much, Kayode. just like the way I mentioned earlier, these trials and disciplinary committee proceedings are done public, are aired, and people, observers are admitted. All the parties are also engaged. People can now, even now, you can Google and find out that the activities of the committee, of the disciplinary committee, but I think probably you need to engage the Medical and Dental Council of Nigeria that will give you more detail on this. The issue of disclosure is part of the ethics of the profession. People can ask questions who consumers who consume what healthcare provides can ask questions and deserve the right to be answered appropriately. And if there are issues, it needs to be communicated in terms of treatment errors or in terms of surgical errors. It needs to be disclosed to the patients or those who are minor to the caregivers. And then you Google now, you will find out that a lot the names and time where people are tried and what ruling was made on them, including the registering them from practicing medicine. I'm aware of at least 2 in the last 2 years. And many other suspension for 6 months, 1 year, and so on. And in some situations, some of the things that are reported are actually done by probably quacks and other professionals, and some of them are jailed. From the disciplinary committee, it is sent to the regular court where they can be jailed. You all remember about the popular case in Adama and in some other states where people are jailed for doing procedures that they are not qualified to do. So in terms of openness, in terms of transparency, I think the Medical and Dental Council of Nigeria is making a lot of effort to enlighten people. Right. That is the reason why some of these trials are done in public.
You know, this conversation can go on, Professor Mohammed. We've not even talked about the challenge you face. And I think recently you said that just 3 pediatric surgeons are serving Kano State. So there's a very present challenge of JACMA, which is now impacting on the service delivery for healthcare workers. But we have to anchor at this point. It's an ongoing conversation. But we need to turn our attention to some other matters of national importance. But we're glad we've been able to give value to this conversation. And we have to thank you gentlemen for giving us that value. We've been speaking with the president of MD CAN, that's the Medical and Dental Consultants Association of Nigeria, and Professor of Surgery, Bio University, Kano, Professor Aminu Mohammed. And also lead consultant to the Federal Ministry of Health on Patient Safety Policy Development, Professor Sonny Semede is a visiting professor, special ed advisor. That CV is quite packed. Thank you so much for your time as well. As Mr. Pascal Achunine, who's Executive Director, Health Emergence International and Social Entrepreneur. Thank you for your time on the program, gentlemen.
Thank you for having me. Thank you for yours.
This conversation clearly continues. Maybe you're watching this from a hospital. If you've got questions or comments, send them in, #CTV Morning Brief. But we'll take a moment now, and when we return, we go over to Benin City, the Edo State capital. I know you have been waiting for this conversation. Stay with us. We'll give you all of the updates in a moment.